Hi, I would like to welcome everyone to another edition of Young IFSO Journal Club. Whoever is joining from across the planet, hello and greetings to everyone. First and foremost, I would like to remind all the listeners that the IFSO, this webinar is recorded and will be online, available for listening on our IFSO website and as well as the YouTube channel. Before we begin, I would like to extend all my deepest thanks to IFSO and Manuela for continuous support of our Young IFSO chapter and our journal club, and we truly feel continued support from them, and we truly appreciate that from all chapters across the globe. Next is I would like with true pleasure introduce our guest speaker. It's Professor Nimeri. I had pleasure of meeting Dr. Nimeri first time in my homeland in Baku, Azerbaijan, where he graciously attended one of our national conferences. And since then, I've met him during multiple IFSO congresses. Professor Nimeri is a section chief of bariatric and metabolic surgery and is a program director of the Carolinas Bariatric Fellowship Program. He is Secretary Treasury with IFSO and as well as the past president of IFSO Middle East North African chapter, and as well as past president of the Pan-Arab Society of Metabolic and Bariatric Surgery. Professor Nimeri is also an associate editor of Obesity Surgery Journal. I personally have read many of his papers, and he has influenced my practice tremendously. Without further ado, I would like to invite Dr. Professor Nimeri for his presentation.
Thank you for the kind introduction.
My name is Abdel Rahman Nimeri, and it's my pleasure and privilege to talk to you today about the optimal length of a bowel and the pouch size when you perform a Roux-en-Y gastric bypass. And I want to thank Dr. Torol Teleshensky and the Young IFSO for the invitation. So this is my disclosure slide. It has no bearing to the presentation, but it shows the types of procedures I perform. I'm going to talk to you today about three things: the importance of the pouch size in Roux-en-Y gastric bypass, and then the differences in limb length, and an important concept called the total elementary limb length. It is important to recognize that when you compare Roux-en-Y gastric bypass, BPD, and duodenal switch, all of them are three forms of Roux-en-Y configuration. The difference in outcome depends on the pouch size or the stomach size, the biliopancreatic limb length, and the total elementary limb length, meaning roux limb and common channel. It is also important to note that there is no similarity between Roux-en-Y gastric bypass and one anastomosis gastric bypass, except in the two words gastric bypass. One is Roux-en-Y configuration, one is loop. Their pouch size, BP limb, and total elementary limb length is different. The third concept that it's important to recognize is that in all looped procedures, as outlined in this diagram, the common channel represents the total elementary limb length. So we have come a full circle in bariatric surgery. We started performing gastric bypass and biliopancreatic diversion by the late Nicolas Scopanaro and Ed Mason into a loop fashion. And then Scopanaro and Griffin changed them to Roux-en-Y, and now Robert Rutledge and Sanchez Bernard changed them back into a loop configuration. When you make a pouch and you ask surgeons how big is your pouch, they say 15 to 30 milliliters. But if you ask them how do you measure it, they don't know. The way to measure it is by measuring the length of staple cartridges used to make the pouch. And the best people who did this are the Swedes. Or we could say the Scandinavians rather. The Scandinavian Obesity Registry have shown us in more than 14,000 patients that the mean length used in their patients is 145 millimeters. So maybe 145, 160, and then another 40. And at 1 year, that leads to a marginal ulcer rate of less than 1%. And that should be the goal. But what's important is that any increase by 10 millimeters of that stapler length, cartridge length, increases the marginal ulcer rate by about 14%. And we have also found, similarly to the Scandinavian registry, that when we looked at 122 matched patients, looked at from gastric bypass patients who developed or did not develop marginal ulcer by endoscopy, that the pouch size correlates with the development of marginal ulcer, and that every 5 cubic centimeter increase in pouch size more than doubles the rate of marginal ulcer. Similarly, there is a very elegant study from Brazil by Rocopio et al. In 2018, where they did CT volumetry and scintigraphy in more than 67 patients and followed them for 4 years. And they looked at pouch size by CT volumetry and pouch emptying by scintigraphy. And faster gastric emptying is associated with a smaller pouch, greater weight loss maintenance, and better food tolerance. So the pouch size is important to prevent marginal ulcers and also to improve emptying. Why is that important? We'll talk about it. Our procedures work by distal delivery of nutrients. The second important concept to consider is that whenever you do a gastric bypass, you're assuming the small bowel length. And this assumption has to be tested. This is a very elegant study by Takino et al., where they measured the small bowel length in more than 400 patients. And they found that the small bowel length is anywhere from 350 to 1050. In general, it's about 7 meters. However, there are some patients who have short intestine, some patients who have long intestine, and we'll talk about this a little later. So let's look at the biliopancreatic limb length. This is one of the most important studies by Nergard et al. From Iceland and Norway, where they randomized 187 patients, BMI around 44, 85% follow-up at 5 years. And they changed the length of the biliopancreatic limb to either 60 centimeters roux limb with 200 centimeters BP limb, or 150 centimeters roux limb and 60 centimeter biliopancreatic limb. And it's important to differentiate this, because if you keep the roux limb constant, you will exclude too much bowel in the 200 centimeter group. The weight loss was different in both groups in favor of the longer biliopancreatic limb, but also the rate of nutritional micronutrient deficiency was higher in the longer biliopancreatic limb. And this is a theme that you will see in all studies. A longer biliopancreatic limb improves weight loss, but at the expense of micronutrient deficiency initially, and maybe at a later stage, macronutrient deficiency. The group from the Netherlands, Fritz Berends et al., have done 2 studies, one in primary gastric bypass. This is the one. It's called the Elegance trial, and the one I'll show you next is the Redo Elegance trial in conversion of band to bypass. In both randomized studies, they randomized a BP limb of 150 to 75, reversing the roux limb configuration. The first study in primary cases had some patients lost for follow-up at the 3 and 4 year mark. There was a difference initially that was lost at the after 2 years, but in the Redo study, there was 95% follow-up, and that better weight loss in the longer biliopancreatic limb group was maintained after 2 years. And there's this systematic review of 13 studies showing that weight loss is superior in patients with a longer biliopancreatic limb after gastric bypass. Now, why is that? It's mostly because of, as I said earlier, distal delivery of nutrients. So making a large pouch not only gives you marginal ulcers, but it does not empty well. Maybe that's one of the reasons roux stasis syndrome is associated with a large pouch. Now let's look at one of other mechanisms, because the mechanisms are complex. This is a very elegant study by Sildinsky et al., where they looked at bile acids in sleeve, bypass, Roux-en-Y with 150 BP limb, and one anastomosis with 250 BP limb. And what they looked at weight loss, They looked at insulin resistance, A1C improvement, and systemic bile acids. As you can see in this graph in the top left, BMI was best for one anastomosis, least improvement in sleeve, insulin resistance, similar picture, A1C, similar picture, and the level of systemic bile acids measured as 0, 4, and 3 was the lowest in sleeve, highest in one anastomosis gastric bypass. So it seems like the mechanism of distal delivery of nutrients and bile to the L cells of the ileum also is associated with some mechanism of elevation of systemic bile acids. Maybe the microbiome also plays a role. So the longer biliopancreatic limb does not need to malnutrition. It has a complex mechanism by which it improves weight loss. So in the final portion of this presentation, I wanted to talk to you about the total elementary limb length in Roux-en-Y gastric bypass and different procedures. So go back again to the study I talked about earlier, a study by Takino et al. That showed that the small bowel length could be as short as 350 and as long as 1050. Now, to make my point, I'm going to test the assumption of the small bowel length in 3 different small bowel lengths, 400, 600, and 800, and see if that makes a difference theoretically on the procedure. So for instance, in the first assumption, we assume that the small bowel length is 600 centimeters. So if you look at BPD, DS, and SADI, and you look at the total elementary limb length, it is 250 centimeters. This is by design, and initially SADI was done with 200, and currently it's done with 300. If you look at one anastomosis gastric bypass, the total elementary limb length is 400, so presumably in this patient it's less robust than duodenal switch SADI and DS. DJB, more robust than one anastomosis, and Roux-en-Y, less robust than one anastomosis, certainly much less robust than these 3 procedures. If you change that assumption of 600 and make it 400, so by making the small bowel length 400 centimeters, nothing changed in BPD, DS, and SADI because we're measuring from the ileocecal valve. However, now one anastomosis gastric bypass and DJB are more robust than BPD, DS, and SADI, and the Roux limb offers protection to the Roux-en-Y that is not present in one anastomosis. That's why this patient and this patient, if not treated well, could develop protein-calorie malnutrition, liver failure, and be the cases reported of mortality that we've seen after one anastomosis gastric bypass, only because the assumption of 400 was not tested. And finally, if we make the small bowel length 800 centimeters, nothing changed in BPD, DS, and SADI, again 250, but now one anastomosis is much less robust, and Roux-en-Y gastric bypass is the least robust, and maybe this patient would have weight gain, and rather than blaming the patient for not following instructions, you should look at their small bowel length. So it's not enough to look at the pouch size, the presence of a gastric fistula, but you need to also look at the small bowel length. So when you look at patients with looped configuration, you need to make sure you are measuring from the ileocecal valve, or at least making sure that there's 400 centimeters distal to the area of connection in cases of one anastomosis gastric bypass. And I'm going to show you how I arrived at this number shortly. So again, if you look at distalization of Roux-en-Y gastric bypass, type 1 distalization leads to an increase in the biliopancreatic limb length, so it's very effective. Type 2 distalization leads to increase in the Roux limb, so it's not effective. And these are all the studies looking at type 1 distalization, starting by the late Sugarman et al., 50 centimeters, 100% protein-calorie malnutrition, 150 centimeter common channel, 44% protein-calorie malnutrition, and you can go down the list. What I wanted to address here is something very important. Let's look at this study. Again, the important group from Norway and Iceland looked at 3 groups of Roux-en-Y gastric bypass patients, 187. First group, BP limb is 60. Second and third group, BP limb is 200. But in the third and second group, they changed the common limb length. So to make it in a diagram and easy to understand, short BP limb, long BP limb, shortest common channel compared to the 3 groups. So group 2 and 3 have a longer BP limb, and a constant total elementary limb length. But group 2 and 3 differ in their common channel. As expected, weight loss is better when the BP limb is longer. But what's important to note is nutritional deficiencies are the highest when the common channel is the shortest. And we've studied this recently. We've done a systematic review looking at all the published literature of distalization of Roux-en-Y gastric bypass, studies from 1993 to 2020, 21 studies. We found that when you look at protein-count malnutrition in type 1 distalization of Roux-en-Y gastric bypass, you need to achieve a total elementary limb length of 400 centimeters at least and a common channel of 200 centimeters at least. And that is why I say if you do one anastomosis gastric bypass, you need to make sure that at least there's 400 centimeters distal to your anastomosis. So at the end, the equation is always between weight loss, comorbidity resolution when you lengthen the BP limb, but that could come at the expense of micronutrient deficiency initially. And if you don't test the assumptions well, you end up with a short biliopancreatic limb, a short common channel rather, you could have protein-count malnutrition. So in conclusion, your pouch should not be more than 145 millimeters. We have found also literature that I have not showed you that circular stable anastomosis has the highest marginal ulcer and structure rate, but for the sake of time, I could not share that data with you. Roux limb should be 100 centimeters. Again, I did not share all the data about the roux limb because of the sake of time, but lengthening the roux limb more than 100 is not beneficial. The more you lengthen the biliopancreatic limb, you'll get better weight loss. We typically use 150 and 75 for patients with higher BMI. And if you distalize, make sure the total elementary limb length is at least 400. The common channel is at least 200 centimeters in type 1 distalization. Again, thank you very much for the kind invitation, and I look forward to the discussion.
Thanks so much, Professor Nemeri, for another fantastic presentation. If you don't mind, I will just start with a quick question, and this question has kind of two parts to it. So one part is, in general, for every single case, even for gastric bypass, do you suggest running the small bowel to assess the total length before performing the procedure? And based on that, you individualize your roux limb, bilirubin, and common channel. And the second part is, I'm sure, as you're aware, there are multiple studies showing significant variation how we run the bowel and what length we come up to. And what do you suggest to decrease those variabilities, please?
Sure. Thank you, Tughrul, again for the invitation, and it's my pleasure to be with you. To answer the second part first, the best way to measure that has been studied is using a tape. But because of simplicity and practicality, I use an instrument with a marking on the instrument. There's a 5 centimeter mark from the tip and a 10 centimeter mark, and I usually measure with that. And for the same rationale, for practicality, I don't measure the small intestine in everyone. So if while I'm running the bowel, I feel like the caliber of the bowel and the direction by which it's coming is changing, giving me a sense that this patient has short small intestine, I might measure the small bowel. I measure the entire small bowel in all cases where I do distalization, because I want to know what the total elementary limb length and the BP limb. But in the regular cases where I'm doing a bypass, I typically don't go beyond 150 centimeter of BP limb. And unless I'm suspicious the bowel is totally short, I usually don't measure the common channel. I just make sure there's at least 300 behind me if I have a concern. But if I ever have to go above 150, then I'll measure the entire small bowel.
I appreciate the answer. Just one of the studies you presented from 2018, I remember it was presented in IFSO London, and since then I also changed my practice in the last 4 years, increasing my biliary limb accordingly. Once again, I appreciate your presentation.
Absolutely, my pleasure.
Professor Nimeri, this is Ryan from China, and may I ask? I see from the first slide, 35% of your case mixture are Windward gastric bypass. May I ask your search? Why do you choose Windward gastric bypass or the indication for gastric bypass in your center? Because nowadays many centers they did a lot of sleeve, but
yes.
yeah.
Thank you, Dr. Yang, and I hope you start feeling better. So I think it's an excellent question, and patient selection could be one of the reasons why traditionally we had some higher rates of weight regain after Roux-en-Y gastric bypass. So I selected for someone with reflux, someone with diabetes, and someone with a BMI below 50, maybe if you extend it below 55. But if someone comes in with a BMI above 55, I'm very hesitant to offer them Roux-en-Y gastric bypass. I also will not choose it for a high-risk patient. So someone on warfarin, someone on novel anticoagulants, Xarelto, Eliquis, I tell them they should have a sleeve gastrectomy. And when I discuss it with high-risk patient or low-risk patient, someone's BMI is 40, no medical problems, no reflux, I tell them that there is a risk difference in favor of sleeve. So at the end of the day, sleeve gastrectomy has a very important role for patients. That's why not all patients could have a Roux-en-Y gastric bypass.
Okay, thank you. And one more quick question. Do you think Roux-en-Y gastric bypass will eventually or some years later replaced by sleeve or other procedures like OHGB? Because like in China last year, we had more than 25,000 cases per year, but only less than 10% were Roux-en-Y gastric bypass. Most of them are sleeve gastrectomy.
Sure. I think the learning curve of Roux-en-Y gastric bypass is different than sleeve, and we're in the process of studying that. It's very difficult to assume that Roux-en-Y gastric bypass will replace sleeve because most of the sleeve complications will need an intestinal procedure. So if someone develops reflux after sleeve, they might need Roux-en-Y gastric bypass. If they develop weight regain, they might need another intestinal procedure. The way I look at Roux-en-Y gastric bypass, as I said earlier, BPDDS are also forms of Roux-en-Y gastric bypass. It's just that their pouch are different, their BP limb and common channel are different. That's why at the end of the day, I look at procedures as sleeve procedure or an intestinal procedure. And I think the learning curve of intestinal procedures is definitely longer. So not every surgeon is going to be doing intestinal procedures, but I think long-term, almost every bariatric surgeon will do sleeve gastrectomy. And depending on the level of difficulty of the intestinal procedure, some will do Roux-en-Y, some will do one anastomosis, some will do SADI and DS and so forth.
Okay, thank you, Professor.
Aaron, I think you're muted.
Can you hear me?
Yeah, we can hear you now.
I want to I usually do my bypasses like knee bypass, like anastomosis gastric bypasses, because I choose a longer for longer BP limb, like about 170 centimeters, and you like BP limb, and then I think it's more feasible for me because the pouch is longer, like about 12 centimeters, and then I don't need to do iron most of the time because it's all anastomosis. What do you think about it? Because this is also called as a divergent anastomosis gastric bypass by Dr. Rui Viguerio. And I think it's a technique for cirrhosis patients because also when you want to revive anastomosis, then it's easy, then you have more touch on top of it. So if you have accumulation or weight regain, then you can always revive anastomosis. And I find this technique very feasible because it's also easy to do, and most of the time I don't those effects. about it, Professor. Can it be done like one anastomosis gastric bypass?
Sure. Thank you, Aaron, for your question. I had trouble hearing it, but I'll try to summarize what I heard. You're asking about the use of one anastomosis instead of Roux-en-Y, especially for super obese patients. So I do feel, because of the technical simplicity of one anastomosis gastric bypass, it will become more popular in the US, just like it has become more popular worldwide. But there are a few things we need to recognize when we do one anastomosis gastric bypass, because it's a looped procedure. So it is not appropriate for every patient. So if someone has reflux, that might not be the best procedure to do. Having said that, I do 4 things, and I recommend people do 4 things if they're going to do one anastomosis gastric bypass. The first you mentioned already, to make a very long pouch below crossfoot. And I think this is important for you as surgeons, because we're not used to doing a very long pouch. And if you take the pouch you do for Roux-en-Y in one anastomosis, you will get in trouble. The second thing is you need to measure the common channel, which is something most surgeons don't do in one anastomosis gastric bypass. And you need to make sure the common channel is at least 400 centimeters based on the distalization literature. The third thing is you need to close Peterson's space. Peterson's space was described by Dr. Peterson in Bill Roth 2, which is a looped procedure. So it's important to close. And then the last thing is you need to tell patients that they might need surveillance for bile reflux, because this is a real entity, and we don't know how bile reflux will act long term in the esophagus. So as long as you do those 4 things, I think it's a reasonable alternative. It has very good outcomes.
Thank you very much, Professor.
I have a question. Just as a background, I'm a surgery resident, so obviously my knowledge may not be as expanded as any of you guys there, but as I'm hearing things, the small bowel length varies significantly between all these patients. You were mentioning anywhere from 300 to 1,000 centimeters. But it looks like whenever we talk about these procedures, you measure the lengths of bowel as a constant thing, like 100 or 150. Is there a benefit of just measuring every patient's small bowel and using ratios of BP limb, Roux limb, common channel, instead of having these hard numbers of 100 centimeters, which may be completely different in a patient with 300 centimeters of total small bowel length and 1,000 centimeters of total bowel length?
Dr. Yang, that's a very smart and bright question, and I think the answer is absolutely. The reason we're not doing it is it will mean we have to measure the small intestine in every patient. And if you look at patients' abdominal wall and difficulty in measuring the small intestine laparoscopically, the risk of small bowel injuries will increase if we measure the small intestine in everyone. But absolutely, I mean, if every surgeon was measuring the small bowel in every patient, we would have had the answers by now. The problem is surgeons who do Roux-en-Y gastric bypass measure the Roux limb and BP limb, not the common channel. Surgeons who do one anastomosis gastric bypass measure the BP limb, not the common channel. And surgeons who do BPD, DS, and SADI measure the common channel, the Roux limb, but not the BP limb.
So, I mean, most of these patients now that comes into your office, they have some sort of a CT scan from a certain point in their lifetime with expansion of EMR and such. Do you know if there's any studies that are being done or any kind of programs that can use those CT scans just to measure the small bowel, that we can just have those data ready for us? Do you know?
Yeah, there are some studies looking at CT and MR enterography. So you let people drink water, so the bowel, the small bowel is stretched a little bit. Because what's important about the small bowel is if you want to measure it, you need to make sure the bowel is with a certain distensibility. Because if you take a piece of small bowel and stretch it, you could really stretch it. So there are studies that have seen they use they let patients drink water, and then after a certain amount of time, they're able to do CT 3-dimensional reconstruction and measure the small bowel length. the accuracy of that has to be tested against. I mean, what would be an elegant study is, let's say, if you have patients who are going to go an abdominal procedure and they're going to have a CAT scan, you do that technique. So then you measure their small bowel length radiographically. Then when they undergo the procedure, you measure their small bowel. Then you can actually correlate the measure.
Thank you.
Absolutely.
Okay, thanks so much for all the questions. I don't see any questions in the chat right now, but if they arrive, I will ask them at the end. Oh, I apologize, actually, there's a question. The question goes as, should we vary BP length in primary gastric bypass patients based on BMI alone, or take into account diabetes or non-response to medical weight loss?
That's an excellent question. So most of the literature of BP limb lengthening has not shown that it improves diabetes as much as improves weight loss. So that's why I do not vary the BP limb length for diabetes. I do make the BP limb length for patients with BMI over 50 the longest, which is 150. And for those patients, I shorten the common channel. And the reason I do that is you have to remember, patients with a longer BP limb, either in one anastomosis or in distalization, don't develop malnutrition because of the long BP limb. They develop it because of the short common channel. Because your small bowel length is finite, as you lengthen the BP limb, you're shortening the common channel. So the way to think about it is, longer BP limb don't lead to malnutrition. It's the fact that you're forgetting that you have a constant amount of small bowel and you're ending up with a shorter common channel is what causes malnutrition.
Okay, thanks so much, Dr. Nemeri. I think we'll keep an eye on the chat. If we get any further questions, we'll come back to that. But I think we will move on with the second presentation of the day. I would like to introduce the speakers for that. It will be Dr. James Yang and Dr. Akash Trivedi. Both of them are general surgical residents at St. Joseph University Medical Center, New Jersey, and they will present their study on histopathologic analysis of the sleeve gastrectomy specimens.
Good morning. My name is Akash Trivedi, and I'm a second-year surgical resident at St. Joseph's University Medical Center in New Jersey. I would like to thank you for allowing myself, as well as Dr. James Yang, to present our research to the International Federation for the Surgery of Obesity and Metabolic Disorders. We have no disclosures to report. Our study that we are presenting today is titled Histopathologic Findings in Laparoscopic Sleeve Gastrectomy. Is routine full pathologic evaluation indicated? Obesity is a chronic disease that encompasses many complex factors. The incidence of obesity continues to rise worldwide at a significant rate, as we all know. The American Society for Metabolic and Bariatric Surgery discusses the benefits of adding a surgical modality in addition to medical treatment for the effective management in patients with morbid obesity. The two most common surgical bariatric procedures performed are the laparoscopic sleeve gastrectomy and the laparoscopic Roux-en-Y gastric bypass, with the laparoscopic sleeve gastrectomy being the most done. Laparoscopic sleeve gastrectomy is the most performed due to its improved risk-benefit ratio, as well as its resolution of comorbid conditions in these patients. Some centers have patients complete a preoperative workup prior to undergoing a sleeve gastrectomy. This includes an EGD to assess for anatomy, as well as H. pylori testing and other factors that could possibly lead to detection of malignancy prior to operation. However, this is not performed consistently across centers because the benefits are not well documented. The ASMBS in 2021 advocated for routine preoperative EGD. In our study, we sought to see that if the resected segment of the stomach in a laparoscopic sleeve gastrectomy needed routine histopathologic evaluation. we conducted a retrospective electronic chart review of patients who were 18 years and older and had undergone sleeve gastrectomy at a large academic hospital. This took place between January 1st, 2010 and October 1st, 2019. All of these specimens underwent a macroscopic and histopathologic analysis. The goal was to assess risk factors associated with abnormal histopathology. This first table, Table 1, allows you to see the demographics of our study. There are a few key points that we would like to highlight in Table 1. The median age, as you can see, is 44 years old. The population of our subjects consisted of 68.3% females. 62.5% of the reviewed population were of the white race, and the average BMI of the entire cohort was 43.2. Other factors included GERD, diabetes, smoking, COPD, sleep apnea, history of an MI, and hyperlipidemia, which can also be seen in this slide. This slide depicts the overall results of our study. A total of 3,543 patients who met the inclusion criteria as previously mentioned were reviewed. Of these, 69.6% of the specimens that were examined were normal, which is the overwhelming majority. 26.5% were noted to have active gastritis, while 2.8% were noted to have follicular gastritis. 0.7% were noted to have intestinal metaplasia, and 0.34% were noted to have GIST. There was one leiomyoma, one lymphoma, and one other malignancy. Next to the percentages, you can see the number of specimens out of the entire population with those results. This next table, Table 2, shows the comparison of characteristics of bariatric patients with normal pathology and those with active gastritis in the sleeve gastrectomy specimens. The white population had the lowest presence of active gastritis in sleeve gastrectomy samples. 21.5% of these specimens had gastritis, while 78.5% did not. This is contrary to the result in Hispanic individuals, in which 37.2% had gastritis and only 62.8% did not. This also differed from Black individuals, in which 32.4% had gastritis, with only 67.6% not having it. Another additional point to note in this slide is that H. pylori was significantly higher in active gastritis specimens at 52.1%. As we move along, Table 3 shows the characteristics of bariatric patients with normal pathology versus follicular gastritis in the sleeve gastrectomy patients. The only statistically significant difference that was found was H. pylori infection, as is highlighted in the table. Bariatric patients with follicular gastritis seen in the specimens were more likely to have an H. pylori infection, as was previously mentioned on the prior slide. Table 4 brings us to our more potentially clinically relevant pathology findings that were of GISTs and intestinal metaplasia. This data is shown here, which is a comparison done of bariatric patients with normal pathology, GIST, and intestinal metaplasia pathologies. There were no comparisons done with the findings of leiomyoma, lymphoma, and the other malignancy because each of these findings was only seen in one specimen each. However, in terms of GIST and intestinal metaplasia, patients were noted to be older than patients with normal findings. Patients with intestinal metaplasia had a median age of 54 years old, and those with GIST had a median age of 57.5 years old. This is compared to those with normal findings having a median age of 44 years old. GISTs were also found to be in 0.4% of the white population, but 2% of the Black population. Furthermore, intestinal metaplasia was found to be in 0.8% of the white population, but in 1.8% of the Hispanic population. So as you can see, those two populations had a higher percentage of abnormal pathologies in terms of GISTs and intestinal metaplasia. You can see the p-values on the right, indicating that these were all statistically significant. As depicted in our results, the most common pathology of the gastric specimens was a pathology of normal. Our 69.6% was a higher instance of normal findings than indicated in similar studies in literature conducted by those such as Clapp, Safan, and Ress. You can see their respective normal percentages in the slide as 50, 54.3, and 35.2 percentages. Across all of these studies, the most common diagnosis was a lack of abnormal findings. When reviewing this data, one might conclude that there is a limited value of routine histopathologic examination. However, there were abnormal pathologies that were found on certain specimens. The most common abnormalities that were found were gastritis and follicular gastritis, and both of these made up a total of 29.3% of the specimens. As previously mentioned, the ASMBS advocated for routine preoperative EGD prior to undergoing sleeve gastrectomies. Had this been done, gastritis and follicular gastritis would have not been considered clinically important, as an EGD should have been performed preoperatively, which would have diagnosed this type of gastritis. Findings of such pathology on histopathological exam would therefore not change the management of the patient. However, the more potentially clinically relevant findings that would support routine pathologic evaluation include those of GIST and intestinal metaplasia, as well as other tumors. Localized GIST has a 93% 5-year survival rate. However, when found with local metastatic disease, this rate drops to 80%. This rate furthermore drops to 55% if found with distant metastatic disease. Findings of a GIST in a sleeve gastrectomy patient can lead to complete and early surgical cure, which would have a significant impact on a patient's overall health. As for intestinal metaplasia, the British Society of Gastroenterology recommends endoscopic evaluation every 3 years due to a risk of gastric adenocarcinoma formation. Therefore, detecting both of these types of pathologies on routine evaluation could provide significant health benefits to patients going forward in their lives. In terms of associated risk factors, this study assessed age, BMI, sex, and H. pylori infection as potential risk factors for abnormal histopathologies. Of these, BMI and sex were not significant. GIST was more associated in those with H. pylori infections, Black race, and older age, median age being 57.5. This association is supported by literature which shows that GIST occurs primarily in middle-aged and older individuals. We also noted that H. pylori infection, Hispanic race, and older age, median age being 54, were significantly associated with intestinal metaplasia, which is also supported by literature. On the other end of the spectrum, low-risk populations included those of white race, younger age, and those who tested negative for H. pylori. A limitation of our study is that these results and conclusions are only for the Northeast United States area, specifically New Jersey. However, this leads to our next slide. H. pylori is a known risk factor in infection rate that differs based on geographic locations. Studies have confirmed a higher prevalence of H. pylori in Middle Eastern populations, including Iran, Egypt, Libya, Saudi Arabia, and Turkey. In our study, H. pylori infection was significantly associated with more potentially clinically significant pathology, including GIST and intestinal metaplasia. Another example of this is that of Japan. Japan has a higher incidence of gastric cancer, approximately 4 times higher than that of the United Kingdom. It was also postulated that gastritis is more prevalent, 60% versus 47%, and severe in Japan with more corpus predominant atrophy and intestinal metaplasia. According to other sources, it was determined that chronic active gastritis is a precancerous lesion for gastric cancer in the Japanese population. Based on these examples and findings, this study should be replicated in respective regions for better local analysis. In northeastern United States, more specifically New Jersey, younger and white patients without H. pylori infection may not require routine histopathologic exam of sleeve gastrectomy. However, similar studies should be replicated in the respective regions to determine low-risk and high-risk populations. Thank you again for your attention. We are now more than happy to take any questions that you may have.
Thank you so much, Dr. Ved and Dr. Yang, for this presentation. I will turn to the floor and the panelists if they have any questions.
I think it's a very interesting study, and we have done a similar one because we always send our specimens to pathology in our university hospital. And there was one study from literature by Mohamed Kerman Sarawi that intestinal metaplasia is also related with hypercholesterolemia. and they have proved that in their study. And I think it might be feasible to also predict that by looking at the pathology specimens. But for the perioperative endoscopy, I sometimes feel that not preoperative but perioperative endoscopy can also be done, because the patient is at sleep and we can see the hiatus and the problems right at there, and then maybe change the squalor of the operation, because like detecting the HP pylori, I think is not very important thing for us for now. What do you think about this?
That would be definitely an asset to have, and I can't speak for anyone, but if the operating surgeon does feel that their diagnostic endoscopic skills are up to that level where they can confidently do a intraoperative endoscopy, and they feel that they can diagnose or take samples and determine those kind of risk factors, then it would be very acceptable to do so, I believe. But at this time, I think most people feel more comfortable having a gastroenterologist do an endoscopy with confirmed biopsies of pathology reports that they can use to direct their therapy, rather than a intraoperative endoscopy during their case.
Okay, thank you very much. I think it depends on also the geographic location, because here we do, most of surgeons, like 70% can do endoscopy and colonoscopy in their practice, but maybe in some countries it's not allowed, so maybe it's the reason, maybe it's not done. Thank you very much, sir. Very good stuff.
Can I ask a quick question, if it's okay?
Please, Dr. Mary.
May I ask how much is it? I mean, for the pathology in your center.
Oh, so cost. I'm actually not sure about the actual physical cost of it. Do you know, Dr. Talashinsky, how much it costs in our hospital?
Well, I mean, it's obviously everything's billed, almost everything's billed to the insurance, but I mean, you're talking in a couple thousand usually, yeah.
Oh, that's quite US dollars, right? Thousands US dollars?
Yes, US dollars, yes.
Oh, that's quite expensive. I'm asking this because in our center, at the beginning, we don't do that routinely, but later we found it is quite cheap here in China to do one pathology examination, only around 100 US dollars. So later we decided to do it for every patient. Just like what you mentioned, that the patient got a report, they will feel safe and they got something to take home. So we just do it routinely for all our patients after sleep gastrectomy.
So do they just do like a gross exam, or do they do like a histopathologic exam as well?
Do both, yeah, both. About 100 US dollars.
Well, maybe we can outsource our pathology exams to China as well. This is interesting.
Yeah,
I know that I saw Professor Nimeri had a question, please.
Yeah, excellent presentation. So what do you do when someone has H. pylori positive on the specimen? Do you treat them for H. pylori at that time?
We personally do not treat them for H. pylori. I believe it's this study was kind of done in a large tertiary center where a lot of these patients were referred for the bariatric surgery. So a lot of like the preoperative assessment as well as postoperative findings were not really followed up very well based on the data. So unfortunately, I just don't have that kind of information.
James, I may answer the question for you. Professor Nimeri, in general, yes, most of those patients were treated 2 weeks after their follow-up, even if they were not symptomatic.
All right, thank you.
And I have another suggestions. When I first read this paper, which suggested by Tokov, I think that we should conduct a global study to to collect all the data from all the continent, different countries from the west or from the east, and to find out any regional differences around the world. I think the data will be very meaningful.
Yeah, and I think it's going to become more meaningful, you know, as the populations that is going to go through bariatric surgery, and like ASMBS, I believe, is now recommending patients with 35 BMI, even without any comorbidities, recommending bariatric surgery in order to help with their weight loss. So a lot of these patients without, you know, a lot of comorbidities and just suffering obesity are going through these pathologic exams of essentially a normal stomach, which and down the line a big healthcare cost as well.
There is one comment also from the floor. Dr. Samarzino commented that this is interesting, especially in bypass, when we leave non-accessible stomach that might have a pathology that we cannot follow. And I want to ask also a question about that. Like if you have a patient with intestinal metaplasia or like a nodular gastritis that cannot be treated by medications, would you prefer to do an operation like transit bipartition, where you can like do a sleeve gastrectomy or a sleeve plus procedure rather than a gastric bypass? I don't know if it's allowed, but what do you think about this concept?
I think that's
yes. So Aaron, so unfortunately or fortunately, the way you want to look at it, you know, transit bipartition and so forth is not allowed in the United States. It's not an ASMBS approved procedure. It's not covered by the insurance companies. There are very few procedures. I mean, only recently single anastomosis bypass has been approved, and we're still having insurance issues with those. But in general, it's a great question. So there's two ways to answer that. One is medically, and one is practice-based. So I think that's where we'll have issues.
Like maybe a SADI, because I think it's approved, but
yes,
maybe.
correct. Professor Nemeri, what are your practice regards to? Do you guys send for routine analysis? And anecdotally speaking, have you seen any significant pathologic specimens that have changed the practice post-op?
Yeah, we typically send all specimens, and similarly, we struggle what to do with the patients who have H. pylori positive. That's why I asked. So we end up treating them, but there's really no literature. However, we have done a lot of work looking at marginal ulcer in gastric bypass and the H. pylori risk. And number one, most of the studies linking H. pylori to marginal ulcer and Roux-en-Y gastric bypass are not well-designed studies. They're not prospective, they're not randomized. They're mostly retrospective series, and most of there's at least one systematic review, but it's on an administrative database and was not well done. So we don't really believe in our practice that H. pylori is linked to marginal ulcer. I know it's off topic, but it's about H. pylori. So typically when we think of marginal ulcer in gastric bypass, we think the pouch size as the number one determinant. And typically we don't test for H. pylori before surgery, and we try not to treat it. And if you look at the guidelines from the GI Association, in a country, just like you mentioned, that's not endemic for H. pylori like the US, if you do an endoscopy for reasons other than dyspepsia, so doing it for reflux or for screening in general, and the endoscopy is normal, they don't recommend biopsying for H. pylori, because if you biopsy for asymptomatic H. pylori and you end up treating it, there's an inverse relationship between reflux and H. pylori. So by disturbing that balance, you might end up with maybe more reflux, we don't know. So that's why if someone gets an endoscopy and it was done not for dyspepsia and it's completely normal, we don't even look for H. pylori. And the counter argument is, well, H. pylori is linked to stomach cancer. So I mean, it's a gray area for sure.
And we have another comment regarding following the H. pylori with a stool sample, if it's still in the remnant stomach. And what is the implication of the study in assessing the stomach before every bypass? I imagine with routine endoscopy, maybe that's a question. And how should we assess the remnant stomach after the gastric bypass?
Is that a, hold on, I'm reading the question. So what is the implication of the study? I think now, right now, the ASMBS is recommending that everybody goes on preoperative endoscopy, these surgeries. So I think that's going to be something that is kind of generalized throughout this kind of population. And of course, based on the biopsies, the follow-up should be whether it's imaging or, as someone had suggested, with stools for H. pylori.
Okay, understood. Let me see if we have any more questions. There's another question. When specimen positive for GIST, are they doing staging? So with the patients that you discussed that had, I believe, cases of GIST, were they staged postoperatively?
I'm not too familiar with the postoperative staging procedure, if you are, Dr. Talashinsky.
Answer to that was yes, they were staged postoperatively to make sure it was not a metastatic disease, I believe, correct. That was a question from Dr. El-Shelby. Okay, all right. I think we don't have any further questions, and truly appreciate everyone's time here. Thank you so much one more time, Dr. James Yang and Dr. Trivedi, for your presentation. Thanks so much again, Professor Numeri, and IFSO Manuela, for your continued support. I'm sure we'll see each other next month or so for another journal club. Happy New Year. Enjoy the holidays.
Thank you. It was really my pleasure.
Thank you.
I appreciate it. Bye-bye.
Bye-bye.